Thank you. I'm presenting on behalf of the investigator team today. Throughout the literature, it has been demonstrated that pain is experienced by 30 to 75% of people with cancer. The development and release of the Australian Cancer Pain Management Guidelines in 2013 identifies standards that can be readily achieved by cancer centres caring for cancer patients with pain without the input from specialist palliative care services. Yet there are barriers to guideline implementation at the system, provider and patient level. The Stop Cancer Pain project is a stepped wedge cluster randomised control trial that uses a suite of evidence-based strategies to improve the uptake and adherence to the standards contained within the guidelines. The trial consists of a control, training, intervention and sustainability phase, with the introduction of the evidence-based strategies occurring during the training phase. Used during all the phases of the trial is a paper-based system for pain screening. The tool that incorporates a 0 to 10 numerical rating scale is born from evidence from a number of systematic reviews which have demonstrated symptom screening in cancer centres to be a feasible and acceptable way to contribute to improved processes of care. The numerical rating scale also meets the standard of routinely screening for pain as per the Australian Cancer Pain Management Guidelines. In the context of the Stop Cancer Pain trial, the screening tool has a triple aim. Firstly, it is to provide immediate patient-reported data to the clinician. The patient reports worse pain and average pain in the last 24 hours. The tool informs clinical practice by identifying patients needing comprehensive pain assessment and management. The second aim is as a quality improvement data collection tool, whereby the data collected can identify the percentage of patients being screened throughout the service, reported pain scores, and then use these pain scores as a measure over time to determine service improvement in the area of pain assessment and management. The final aim is as research data. Patients are asked at the bottom of the screening form if they can be contacted by the research team to participate in the Stop Pain research project. If patients do not opt out, they may be eligible for recruitment to the trial. To date, the study has found that despite the intended triple aim of the tool, people involved in the study, including medical, nursing, administrative and clinical trial staff, has seen the introduction of the screening tool only in terms of collecting research data, and as such, screening rates throughout the early sites has been less than optimal. The following direct quotes from site participants support the concept that screening has been seen for research purposes only. I thought form distribution was only for 2 weeks and 2 weeks is up. How many more participants do you need before we can stop handing out this pain screening form? And finally, patients are refusing to complete the pain screening forms as they completed it at their last visit. This misinterpretation of the purpose of the screening form has implications for other studies that are making dual use of data. Implementation researchers need to take a proactive approach to communication with all participants. It cannot be assumed that staff and patients participating in implementation research have background knowledge of implementation science. Framing the study or speaking the right disciplinary language when engaging with providers and patients is an extremely important factor to overcoming the barriers. Solutions include providing an explanation to patients that screening will occur at each service encounter and that the data provided assists with a whole of service improvement. This gives context to routine pain screening, especially for patients not experiencing pain. At the provider level, using language such as quality improvement project with robust evaluation may better support comprehension. And at a system level, screening is better embedded into routine practice rather than seen as an additional task to an already busy workload. For anyone involved in getting research into practice, you know what a complex, messy and challenging task it can be. Throughout this presentation, I've highlighted the challenges involved in using data for clinical and research purposes. Though through identifying proactive solutions to these barriers, researchers will be able to ensure that these barriers can be overcome.